I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
Welcome to this episode of IDD Health Matters. We're coming to you from the American Academy of Developmental Medicine and Dentistry Conference in Denver, Colorado. And we have a wonderful guest today, Dr. Seth Keller. Welcome, Seth.
Thank you, Craig. It's really wonderful to be here at the IDD annual conference.
So, Seth, you've been involved in this field for a while.
Almost 20 years.
Almost 20 years. Tell everybody what you do in this field.
Well, I didn't always do what I do now, Craig. I'll admittedly so. So I'm a general adult neurologist. And as a general adult neurologist, that means I treat and care for adults with different neurologic complications. And I work in a community-based practice in southern New Jersey. I'm from Philadelphia. And the kind of things that I treat as a neurologist, epilepsy, migraines, stroke, dementia, those are general things that I treat. And I, like most general neurologists, were really not trained in developmental disability. So I really didn't have...
Like most of us in general, most physicians weren't.
That is sad but true.
Yes,
Isn't that sad but true?
Is.
We've learned that. So my upbringing in medicine and neurology was not based at all. And really by happenstance in my field in epilepsy, which is really what I really like, is when I really got to my current practice in 1996, I gravitated towards complicated patients who had different difficulties in epilepsy, and that was developmental disabilities. So I became an expert pretty quickly in caring for complex epileptic care in developmental disabilities. But you know what, Craig, in my early formative years, I'll call it my formative years, I'll say it like that, it was basically institutionalized care. So many years ago, what I really believed is the so-called normal of developmental disabilities, that people live in institutions and just how their lives are. And I really had that as my initial introduction to developmental disabilities. But shortly after that, and this is like 20 years ago, I started even giving presentations. I actually went around the country and gave presentations on developmental disabilities and epilepsy. And one day, one room was my colleague, Phil May. And Phil May, at that time, was one of the leaders early on in the AADMD, and in fact, became our first president. And it was based in the very beginning, within a year after the AADMD, American Academy of Developmental Medicine and Dentistry, was formed, after this meeting by David Satcher, the then Surgeon General of the United States, to bring together healthcare practitioners, oral healthcare practitioners, to recognize the terrible disparities, the terrible difficulties that people with developmental disabilities were not getting access to quality services generally everywhere. And it was really out of that, when the AADMD was first formed, I saw this amazing discussion with Phil May, and I started meeting other people, even, certainly like yourself and others. And it was like meeting family, meeting people that had the same values that I had about caring, and different people who really needed the care. That was the first step. The second step was actually more valued, more of a social cognizance of the population, more as like a medical standpoint of the developmental disabilities. But the second awakening, I would call that, my mind was really more working toward the social side of advocacy. And honestly, I would really think that was probably my biggest awakening, aside from the medical side of developmental disabilities, was seeing that people are people, they have values, they have dignity, and I should respect them like everyone else, because that doesn't always happen, as you know.
It certainly doesn't. And there have been recent studies that have shown that many physicians think that people with disabilities have a lower quality of life, and that clinicians may not feel comfortable in providing health care for people, or may not welcome them into their practices.
It's sad but true. And I really think, in my personal life, I wasn't really brought up with anyone with developmental disabilities. Certainly, I know Down syndrome and autism, but you certainly know about it, but I really didn't have that personal connection. And I wasn't trained as in medical school at George Washington University Medical School, or my neurology training I was a Navy neurologist. I was a Navy neurologist, and I didn't get anything because it's not there. It's not really against the organizations or the medical societies that I work with. It's because really across the board, it really hasn't changed too much in all these few decades, that there really hasn't been much advancement in terms of getting that kind of care or knowledge or experience within our medical practicing experience. So what do you expect?
Right. Right. And that's one of the things that this organization is really working towards, though, is to implement training in all healthcare provider programs.
Absolutely.
About how to provide healthcare for people with IDD.
Right. And I know that the leadership of the ADD, yourself, myself, and our great colleagues and friends, basically they have taken it to heart about that exact point, about reaching out and trying to find the knowledge and expertise and then sharing that information to, and I don't want to say the ignorant, but those that don't know what they don't know. And I'm not really trying to judge them. They don't know what they don't know.
I didn't know what I didn't know.
I was still trying to figure it out.
Until I walked into an intermediate care facility and began trying is really the word,
right,
provide health care to people with severe and profound levels of intellectual disabilities, complex medical problems, complex mental health conditions.
Right.
And I realized very quickly that I was not trained to provide this type of health care. And before that, if you had asked me, well, can you take care of someone with disabilities? I'm like, yeah, I know what Down syndrome is. And that's pretty much, okay, well, yeah,
right,
sure, I know what that is. But then what you really realize is that there are some special ways of thinking and different contexts and different ways to look at things when you're seeing people with intellectual and developmental disabilities. One of the bigger ones is behavior being a form of communication.
Absolutely.
And not just something that they do because they have a disability.
Absolutely.
I mean, I bet you have stories of people who had behaviors, quote, or adverse behaviors that ended up having a seizure disorder.
Absolutely. Yeah, I think that is really true. I really am diagnostic overshadowing.
Yep.
That the term as you're describing.
Yep.
Yeah, I mean, it really is the term. It's that bias, that inherent bias, and it's really not. It could be everyone. It could be the family member could have the same bias too. They look at the person. Oh, it's their autism is acting that way. But there's no doubt that a lot of health complications could manifest themselves, and they're immediately blamed by the underlying developmental disability doing it, rather than some kind of illness, disease, or pathology causing it, and it really prevents their ability to get the right kind of care. And the sad part, and this is really the difficulty with behavior issues, and this is really where I think it's very difficult with behavior in particular, is instead of looking at the root cause of what is triggering or driving that behavior, they might be automatically treated pharmacologic measures to suppress, reduce, mitigate the behaviors with psychiatric medication. And so you pile on or add behavioral psychiatric treatment medication, which into itself may cause additional difficulties, almost like a chemical restraint in some respect. And that's really tragic. I mean, you can only imagine that if that was you or me, that you're giving a medication, and it's only because you can express yourself. You can say to that person about why you're acting away. You say, oh, I feel, or like side effects from medication, which is really what I'm getting at. Side effect. How does someone that's polyverbal, nonverbal, or doesn't really know the ways and means of expressing themselves, saying, I get lightheaded, dizziness, stomach problems, I feel confused. How is that person that doesn't have the wherewithal to kind of explain themselves, they're going to act in certain ways? So that behavior is manifest. So that behavior looked to someone that doesn't know, they might treat it as a pure behavioral problem, give them more medication.
And I want to be clear, it's not because the physician necessarily doesn't care or doesn't, just has no interest in treating this person. They are just unaware of the different ways that people communicate, as I was. I did not recognize those types of things. You were talking about medication side effects. Let's say you're taking a medication and it causes you to be nauseated, but you can't tell anyone. You might start becoming agitated around meal times or when someone offers food. You might start throwing things because you don't want to eat.
Put your finger in their mouth.
Put your finger in your mouth. Those types of things. And we so often
you got to read these behaviors.
Might say that this is just what that person does, or I don't know why they're not being compliant or whatever it is, without ever thinking about what actually could be going on that really is a fixable or treatable cause.
These difficulties are really a challenge, and they really are. I mean, and really what also makes it also challenging is that often the behaviors that we're so-called treating or evaluating often are those that we don't see ourselves. These are stories that are brought to us by the care providers, the family. They're saying, my son, my daughter, my client, they're acting this way, and there's the person sitting next to me, and they're not doing it right there. And so you're basically also basing it on the person doing a narrative, describing a story, and you're trying to, and not to be cynical about the person telling the story, you have to question, what do you mean by this? Like, what are they acting like? Because they're also not to not trust the person telling a story, but they're all like, I'll give you an example, which is difficult. Is they're, say in a group home example, or even in institutional care, there's lots of different people that have maybe certain challenging behaviors, say autism, and they're one individual that's supposed to do a lot of work in caring for all these different people, and they have all these people acting out. And they're going to say, oh my God, they're all acting out. Doctor, they're all acting out, and they're, because they can't do it. They're having a hard time. I'm starting to be slightly facetious. It's not really fair, but I think that sometimes drives some treatments. Sometimes people, who am I really treating? Am I really treating the person when they're just doing their thing with the behavior? And I hate to say this, and I think whatever will come out here in discussion, I do think there's something we have to be very careful on what information we receive from the people delivering that story to us. We have to really be careful.
I think we have to be careful, but we also have to recognize that sometimes the information that we get from the direct support professional or the family member is extremely valuable.
We need it.
We need it. But we also have to maybe know what questions to ask,
right,
to help figure it out, because that person who might be providing you the information may not know the medical terminology and may not be able to explain it clearly. But they may just say, well, this person's not acting right. He used to be able to feed himself and eat on his own, but now he's requiring a lot more assistance. So what could that mean? And that's part of this education that we need to understand. What are some of the more common things that could cause something like
and what they do from an educational standpoint, I would say that we in the developmental world do this uniquely, is develop that relationship with the care provider, the caregiver. Because in many cases, and this is, I guess inherent within the field of developmental disabilities, many times we work with direct support professionals, these professional caregivers, and the professional caregivers may not always be savvy or educated or knowledgeable about even communicating or how to relate to doctors or nurse practitioners, others. So they may not even really know, or the doctor themselves may not how to relate to them.
Right.
So you have this difficult relationship building, and it may not, and based on how that is successful or not, may have an effect upon the ultimate care that the person's given. You need each other. So I really think what's really very basic, and it's maybe should be more obvious than it is having these discussions with the care team, this back and forth dialogue about relationships, communication, data, what's important. Because I rely, as all practitioners do, you rely on that care provider, the mother, the father, the care provider, to really give you the information, the data, the facts, the perception, and that perception often is what drives a lot of healthcare practitioners to know what to really do. It's not often done in that little visit. I'm seeing the person who may not be able to speak at all. It's really based on the story that they drive to me. So you really have to get into that.
Yeah. So we could probably talk for many hours on that particular thing, but I want to jump to something else that I know you're very much involved in, and that is dementia.
Yes.
Talk about that a little.
Well, in my general practice as an adult neurologist, I do focus on the aging, the older population. So that would include people that have had strokes, Parkinson's, dementia, or Alzheimer's in particular, the most common form of dementia. And what's very unique in dementia is those that have Down syndrome. Individuals with Down syndrome have an extra copy of chromosome 21, and on that chromosome 21 is the product of beta amyloid protein. Beta amyloid protein, which is what we all have, is made up, is for our cell structure. It's very important to have, but if you have too much of it, it builds up in the brain. And that buildup in the brain is what ultimately is part of the trigger that leads to a cascade, which is actually Alzheimer's disease. So people with Down syndrome have a huge risk of getting what's called early onset Alzheimer's disease at some point in their life. And early onset, its definition is before 65 years old. And in fact, many people with Down syndrome actually are developing it in early 50s or even in their 40s.
40s, yeah.
And it is a shock. It is such a shocking thing for everyone, certainly, obviously for the person. And I think philosophically, trying to get one's mind wrapped around, and I think really the story would be someone, your son, your daughter, the person with Down syndrome is living their life, trying to live their best life they can all possible within the system of care they can get out of.
Sure.
Education, training, medicine, society, you're fighting, and you're doing the best you can. But then they have this genetic propensity to get this horrible, tragic disease at this early adult life in their 40s and 50s, and it's almost like hitting a wall where all of a sudden they start losing their function, the ability to understand, and their memory and their speech and their walking, and what makes early onset Alzheimer's and Down syndrome very unique, different from what's called later onset Alzheimer's, is it happens quicker earlier on, and also it's a very rapid effort. It happens very quick, and within 5 years, a lot of them are dead.
Wow. Now, Seth, you know, we talk about
Sad, very sad.
It is. We talk about, you know, Alzheimer's, and we see cognitive changes and a person's ability to think and an ability to communicate. Now, if a person is already starting off, say, with some challenges in verbally expressing things
as a baseline,
as a baseline,
absolutely.
How do we diagnose dementia in a person like that?
That's a great question, Craig. Is that really what you need? And you have to know the person of who they were. And let's call it the best past performance. And it's basically looking at their activities of daily living.
So you look at the skills and maybe changes in their skills and things that they normally could do, and changes
as their best past performance, their skills, their activity of daily living. So for me, because when people see me with dementia, they've already have it. They're already developing it. So I didn't see them when they didn't have it. So the only way I know, what were they like before? So that's with anyone, whether it's with Down syndrome or with a neurotypical population with Alzheimer's, you have to know what they were like before. This is what they're at now. So to really know the change, because you can say someone coming in now with Down syndrome and they're different. I said, what's different about them? This is the buy. This is the overshadowing part.
In order to identify change, you have to know the baseline.
Absolutely. So the way to know baseline is the storytelling, is the narrative that's provided to me by video, by picture, by story, and I ask that again and again. Tell me about Mary and Joe 5 years ago, 10 years ago, and then you start getting these stories. Oh yeah, they were able to, and some people higher function with Down syndrome. Oh, they were able to take a bus by themselves, and they had a job by themselves, and they did this. I helped them a little bit, and you get these stories, and then you see this person in front of you, and you're almost like shocked. You're saying, oh my God, they've really lost abilities and skills, and that's a dramatic thing. But one thing that's also true, even though they have a huge propensity of getting early onset Alzheimer's, there are also other reasons that also might signal why they're losing skills, and it may not be Alzheimer's.
Such as?
Well, one example is social issues and behavioral issues. So I'll give you an example, which is really not uncommon. And I certainly don't mean to stereotype people with Down syndrome, but they're very sensitive to their environment. So they would say if they're getting older, their mom and dad is also getting older, and their work situation is changing. So if someone gets sick or dies, or they get moved to a different care location, they might react to that situation and regress or lose skills because they're emotionally pulling back, like almost being depressed. And that ability of losing skills is only because they're depressed. So there are false nature of giving a diagnostic overshadowing in that extreme.
In that way.
You're actually, you're giving them a false positive. You're actually saying they got a diagnosis when they don't have it. I see that. I mean, I see that. And that's like, because doctors know Down syndrome, Alzheimer's, they have a change, ipso facto, that must be Alzheimer's. And I've seen it too many times in my practice where that's not true, or someone that's even a lot younger. I said, that is not possible. There's no way they're losing skills, and that's Alzheimer's disease. There's what's called regression syndrome in younger people. But be it as it may, the eyes must be really wide open as to looking at the root cause of the change. One is recognizing the change. We're talking about skills, looking for skills earlier, and then also trying to identify the skills and then trying to quantify it. So a lot of it is trying to objectify these changes that you're seeing.
Now, you've done some work in developing a tool or two to be able to do that,
yes,
right?
Yes, I have.
All right.
Well, thank you for that.
Tell us about that.
Well, the reason why I've done that is because trying to care for someone and say, follow them over time, or if I want to treat them for a subjective like behavior or memory, is I want to be able to track it and provide some kind of objective evidence of if I'm giving a treatment, how am I going to know the treatment is going to work? And the tools, the assessment tools that have been out there for people with developmental disabilities have been very poor because they're not apropos for intellectual disability, language dysfunction, and you're going to miss the boat on being able to have an accurate ability. So for a long, long time, I certainly did in dentist, there have been a number of tools created by psychologists and different researchers that do try to provide an assessment of functionality, basically. It's like a skill set kind of functionality on tracking people with developmental disabilities. And I help develop a tool similar to that is more apropos for changes and signs of dementia that is basically based on a Likert scale. And the Likert scale would be a numerical scale.
Number like 1 through 5,
It's
right?
1
Your
through
ability
5.
to function on one of these things.
Exactly.
So that's what we mean by Likert.
Exactly. Yeah. Five in essence would be they're totally independent upon activity of daily living. And the opposite with 1 is they're 100% dependent.
And so the idea is that you do this assessment
Every 6
on a
months.
regular basis
and
or every
follow
6
people.
months. And then you can identify changes from that person's baseline. You can also identify how rapid a change might be occurring.
Absolutely. And the tool is filled out by the caregiver. It's filled out before the visit. So I'm not, and it's also because in any offices with any practitioner, the clock is ticking. I mean, you got 15 minutes, 20 minutes, whatever. So you really got to be able to rather quickly be able to come up with information. Information are provided, you look at the information, then make an assessment all within 15 minutes, 20 minutes. And so basically this information is created before the visit. They're told to bring in the form in, and it's basically able to look at it on a few pieces of paper and compare it from the time before. And they can tell me the story, Joe and Mary changed, but you can actually objectively see based on the numerical value of a skill. So basically what you're doing, you're tracking particularly of activity daily living that they're now losing ability of what they used to do before at some level.
So this form is available out there, right?
Absolutely, yes. We have 2 forms that we use. So the one,
and when we say we, it's the National Task Group on Dementia Practices.
Yeah, intellectual.
Help me with that.
The National Task Group on Intellectual Disabilities and Dementia Practices. But we're really well known as the NTG.
Okay, and you mentioned you play a big role in that organization.
I'm the co-president of the National Task Group, and in my leadership role alongside Matthew Janicki, who Matthew Janicki has been involved in aging in developmental disabilities for many, many, many decades. I'll call him the grandfather. Yeah. So I'm actually honored to be alongside my colleague. And really the NTG, just like the AD&D was formed of grassroots and people together, the National Task Group, which a number of years ago was actually part of the AEDMD. So several years ago, we had gone out to be our own 501(c) organization, but be it as it may, the National Task Group is a multidisciplinary organization made up of doctors and nurses and psychologists and occupational therapists and family advocates. So we actually are a holistic group also looking at the issues related to not just Down syndrome in particular, even though they have a high prevalence of Alzheimer's disease, it's really all people who are aging and you're concerned about decline. Because really what's really happening is that, and this is really, I guess, for anybody, is that many, many, many years ago, people with developmental disability were not living long.
Right.
And they weren't living long.
And so now people are living longer, so they have the luxury of experiencing many of the challenges that
they can get gray hair like me.
Gray hair, arthritis, dementia, all of these other things that we see with
And the sad thing, which is really true, is so even the notion, Craig, that there was early onset Alzheimer's and Down syndrome wasn't even known about decades ago.
Because people died at 30.
Absolutely, and younger. Yep. And that's really tragic. And really just a side story of this one, I may have told you this before, Craig, is I had last year went to Ukraine.
You did. Wait. I want you to tell that story. But
okay.
Before we get into that, I want to make sure people know how to find the forms.
Yes.
So it's the-ntg.org.
That is
the
correct.
Website. But you can also just look up National Task Group on Dementia.
Absolutely.
And it'll pop right up.
Yes.
So those of you who are out there that are interested in finding the forms that Dr. Keller is talking about, you can find it on the web. They're freely available, and I think they're in a number of languages.
Yes. Well, I'm just going to briefly just describe the form. The one form that the National Task Group had developed early on at the very beginning, almost over 10 years ago, was called the EDSD, the Early Detection Screen of Dementia. Right. And the EDSD basically is a form for caregivers, and the notion of what to do with it is an early tool to help even identify that any change has even occurred whatsoever for any reason. And because basically the problem is early on is knowing that there's really a change that has happened to people with developmental disabilities of losing skills, losing abilities. So we had devised the early detection screen of dementia, the EDSD, which is really the one in multiple languages. It's now internationally used, multiple languages, and it's done by caregivers. And it really just can give a statement in the tool and it tracks different behaviors and different signs of dementia or different aspects of care and says from 1 year to the next, has someone changed? Are they different? And once they make certain points, they've changed from year to year, that information would then be brought into the doctor. The doctor would then say, well, this person has changed. You've identified there's a change. Now they do an evaluation and workup to find out why. Not that they may definitely have dementia. Maybe it's hearing loss, vision loss, or normal aging.
Person's had a loss in function. Let's figure out why.
Exactly. And that's
Gotcha.
that's the EDSD. The EDSD is really meant only to drive the conversation, to get assessed and evaluated. The
form you're talking about that you helped develop or developed is what?
The form that I developed is based on the EDSD. It took the EDSD and made it into a Likert-based tool of the same type of information that made it more objective to track change. The EDSD is yes or no, year to year. It's not sensitive enough to track things.
And both of those can be found
Absolutely.
on the website.
Absolutely.
Great. Okay, now tell us about your experiences in Ukraine.
Well, the reason why, I mean, I could take all day on Ukraine. The reason why, in June of last year, June of 2022, I was asked by an international organization, Disability Rights International. And Disability Rights International, the executive director is Eric Rosenthal. And Eric has been running this organization since 1993. An attorney by nature, and he basically grew up in the Washington, D.C. area and really learned the world. He traveled around the world and really got a sense of global health and global issues, and really soon recognized that people with developmental disabilities were living in institutionalized care around the world, and in particular Eastern Europe. And it really gave him the perspective of the wrongs, basically, of the way that care is being provided in a lot of these prior Soviet bloc countries, and he took it to one of his missions of Disability Rights International to go into these different countries and basically almost as a watchdog organization with a big camera and a big microphone to look for signs of abuse and neglect and report them back to the UN and other international entities to almost like force the hand of these countries, shut down institutions, provide better developmental care. And Ukraine, as much as Ukraine's kind of, been out of the arm or umbrella of the Soviet Union now under Russia, it's still a prior Soviet country that basically, culturally speaking, still is back in the day, almost like the way the United States was back in the 40s or 50s, and they're still living it. And what brought the issue of attention is they're in a war now. Russia, the Federation, has attacked Ukraine. And what Eric Rosenthal and Disability Rights International is want to keep the spotlight on Ukraine and show that, God bless Ukraine and all the work they're doing and try to, save their country, which is, I'm all for Ukraine. What about the people living there, the people with developmental disabilities? So he has gone through a lot of different countries in that area, not just Ukraine, and he basically has been going into Ukraine for a number of years and wanted again to go back into Ukraine. So one of our colleagues, Marissa Brown, Georgetown University, she had run the USED program there for a number of years, and as her leadership role, she had been working with Eric Rosenthal, and she had gone to Ukraine, and they wanted to go back again. And Marissa was not able to go, and she suggested that I would go. So I'm friends with her, and she thought I would fit the bill as being the medical eyes and ears of Disability Rights International, and we did it with the BBC.
What was that like?
It was surreal. It was surreal. I mean, I certainly, as an American, I watched the news. I followed the course of history. I watched, everything going on, and my heritage is I'm Eastern European Jew. And so I have my heritage is actually partly Belarusian, as it turned out later. That my wife's from Ukrainian. This is, I've been American now multiple generations, in America, my family. But I definitely was like, oh my God. Going first, I was scared. Sure. Naturally scared. My wife, I'm hearing about this when I asked about, and I really had to do my due diligence to kind of find out why am I going and what role would I serve, and also how safe would it be. And, to my practice, and I, I talked to Marissa Brown, who had been there, who had been in Ukraine with Eric Rosenthal and Disability Rights International. They already had done an expose on it already. So I saw a video in the BBC, already had done a piece on what they did. So I really had a general sense of what it is they would do. But, Craig, one thing that I found very difficult, I'd never done I was never a watchdog before. I was someone who takes care of patients. I see someone in front of me who are sick, and I'm providing care, right?
You do, sure.
That's not what you do as a watchdog group. What you do is you stand back, you take video pictures of abuse and neglect, and you report it. You're not there to treat the person. And I knew that, and I had to sign a contract. I had to understand my own role response. I get it. I had to do that. So I really had to think from a moralistic and ethical standpoint. How would I be able to do it?
I can see the challenge in that.
I didn't even know. I mean, I really didn't know. How does one know? How does one ever know how you would feel about that? So that I had to mentally get my mind wrapped around that. And I had, conversate with Eric and talked about it. But I knew my role. And so I definitely put my hat on as a disability rights watchdog physician and knew what it was. But definitely in the last years of my life in developmental disabilities, it's been very person-centered and humanitarian-based. And so for the last number of years, I've been working with our colleague Rick Gadadi of Positive Exposure very closely. And so Rick Gadadi, as you know, Rick Gadadi, it gives the face of humanity and a personality to people that we in science and medicine, before we would have them up against a dartboard with black across their eyes, you see them as a disease.
You're talking about medical pictures.
Absolutely.
With a particular genetic condition.
Absolutely.
In medical text. Yes, just very stark photos of, like you said, a person with their eyes blacked out and seek to look at their physical characteristics. And Rick has changed that quite a bit.
In a huge way. I mean, Rick Gadadi, just thought I'd bring this up. I mean, it's been, I wouldn't say an awakening, but yeah, I would say it's an awakening in terms of my own perception or a lot of people's perception. So for me, when I see someone, and I know when naturally I see someone, I see them as a person, not as someone with epilepsy, not someone with Alzheimer's. I see them firsthand as a person. Like, why not? You're a person. I'm a person. I see you as a person.
And just to expand on Rick a little bit more for the audience.
Yes.
So Rick was a fashion photographer and really kind of moved into this world of taking photographs of people with various genetic conditions and intellectual disabilities and presenting them as real people, which is what they are.
Absolutely.
They're not a diagnosis.
Right.
They're a person.
His story, I mean, you'll interview him.
Yeah, I will.
His story's so fascinating.
I will.
That story, how
he'll be on.
The pivot of how he did it, is, I mean, without me giving away, he can speak for himself. But basically, the way he did it, and basically, I think his messaging. So anyway, so when I went to Ukraine, and again, I am who I am, I went in there very personal. And I've been with Rick, and I work with him. I've been going on some of the photo shoots and video shoots. So I've actually been there where you're talking to the person, you're making, not that they need you to make them who they are, you're showing them in the way they are as people. And so here I am in this personal way. I mean, I don't want to make it any more dramatic than it was, but I was in my mind. I really was in my mind. But the other thing also was because I focused on geriatrics, I also was interested to see what was I going to see, what kind of ailments, what kind of diseases, what kind of situations where people with developmental disabilities is going to be in. And I really was certainly curious about that. And I, as many physicians, also have spent many years working in institutionalized care in the United States. That was my beginning in
mine as well.
And so my own sense was that, I understand an institution. I understand the history of the institution in the United States and Willowbrook and all the different, I think I know the story quite well. But, now it's, 2000, whatever, and I've been doing this for 20, 30 years. And so I think I know what I know, and my eyes are wide open, and I'm not, trying to gloss over some of the difficulties I see in our own United States state institution, which I'm all about community-based care and family support care. But I really went into also Ukraine with a history behind me of expertise and knowledge in the United States and doing some due diligence. So when I went there, I would say the one thing that I noticed is that to carry the American flag in my mind, like here I'm an American. I went to Ukraine and I went there thinking I know everything United States. I know how to do care. I know standards of care. I went to great medical school. I got training. I'm AEDMD past president. I know what's right. I know the values and I know what is what it is, but I got a rude awakening pretty quickly when I went into Ukraine because of their culture and all the issues that they're facing. And I'll give you can I give you a quick story?
Yeah, please do.
It's almost a little embarrassing story. So getting into Ukraine is not easy. It's not like you can just drive into Ukraine. So you can't just do that. So basically, from a practical standpoint, to get into Ukraine, I'm in the Philadelphia area. I flew out of Newark Airport to get in. I flew from Newark Airport to Istanbul, Turkey. And I met Eric Rosenthal. He lives in Boston. So he met me there. And I actually met him for the very first time. Other times it was Zoom. And so from there, we spent overnight in Istanbul, Turkey. And the next day we went to Bucharest, Romania. This is now getting closer to Ukraine. I mean, I wouldn't say I think I could have recognized Ukraine on the map beforehand. Now I certainly know. And this is now getting to the western side of Ukraine. Romania is basically on the western border of Ukraine. And that's where we basically, our planning, our operation was in western Ukraine. And the war at that time, this is, already last June, was already all on the east and the southeast part of the country at the time. So I knew from a due diligence standpoint that we were entering into the area of Ukraine that was quote unquote safe. So I felt that was safe. But getting there, so we flew from Bucharest, and then the third flight was getting into the northeast part of Ukraine, into Romania, in this small little airport called Suceava. And Suceava, Romania, is near Transylvania. So it's a little gift shop. They have like Dracula stuff. It's so funny. They do. It's really funny. It's a little airport. I mean, it's Dracula, Transylvania. The Carpathian Mountains are like near there. So if you want to go to the Transylvania, you have to probably go through Suceava. In Suceava is where we met Helena. Helena was our Ukrainian operative. She's from Kyiv, and she basically drove from her home in Ukraine and drove across the Ukrainian border and met us at the airport in Suceava. And literally, we got in her car, Eric Rosenthal and I and Helena, and we basically an hour and a half got to the Ukrainian border. And then you see, as you're getting closer to the Ukrainian border, this is really my first sense of like life in Ukraine. On the Romania side, there were mile after mile after mile, 18-wheeler trucks that were lined up trying to get into Ukraine to deliver goods, fuel, goods for their citizens, mile after mile. And basically the cars were sitting there sometimes for days. And the drivers of the trucks, a lot of them are sitting outside, either playing cards or I don't know what they're doing. They're sitting there, and we were in this car. We were able to drive relatively close. Helena, who's basically Ukrainian, we got to the checkpoint at the Ukrainian border and basically took our passports, got out, and basically in a few minutes, we got right into. I didn't need a visa. I didn't need anything, but I did know that once I was in Ukraine, the U.S. State Department would have nothing to do with us. We were on our own. So we knew, and I knew that if something happened, God forbid, it's not like the United States Department could come in and save me. It was so anyone American citizen that go into Ukraine, I mean, it's on their own own ability. I wouldn't say it's totally like that. And also I knew that we were working with the BBC. The BBC was now going back on part 2 of their expose. So they were basically their week that we were there. They also we were with them. They were with us. We were basically going from institution to institution. And the institution, just like in the United States, they're not like in your cities. They're basically put in like nowhere's land. They're basically far away in the most rural area. We set our base of operation in this town called Chernivtsi. Chernivtsi is in the southwest part of Ukraine, 250,000 people. It's a big metropolitan area, and it really looks like many other places in Europe. Very Europeanized. There are definitely buildings that were post-Soviet Union because Ukraine was part of it. But it was definitely, you could really like go. I've been to Eastern Europe and other countries, and it really looked very. And you honestly, you wouldn't know that there was a war going, except for a few things. One, besides going in with all the trucks lined up, is all the gas stations were closed. They had fuel shortages, and every once in a while, a gas station would open up, and there's like a run to the gas station.
Everybody goes, and then it's
again. And the other thing is that since we were doing our road trips against institutions, we had to carry around our own fuel. So in the back of her Jeep that she had, we had these fuel tanks. So we had to crack open the windows as we were driving around because we basically had fuel in our cars. You didn't know if you were going to get fuel. The other part, you saw military personnel. So you see people that were like walking the street, that were just walking around. They're military because they basically closed Ukraine, and people that are age 18 to 60, men, are not able to leave Ukraine now because of the war. So you saw people in uniform walking around, and then air raid sirens. So in my first day or two in Trinity, I'm in this hotel that we stayed at. It was a really nice hotel. They had the bar at the top. They had a singer where they held weddings. It was really kind of nice. But an air raid,
you hear that,
this whining, high pitched sound, and I'm like on the 5th floor of this nice place we were staying at, and I'm like, oh my God, air raid siren. So I'm out in my balcony, I'm looking at the people around, Craig, and I'm looking for people to run for cover. No one budged.
Yeah.
No one but no, because they really knew that this was part of their life, and they knew that in this area in Trinity, southwest part of Ukraine, they'd never been bombed. So they had a relative safety or self-confidence, I suppose, or they felt safe. But that was Trinity. You go to other parts, Kharkiv, which is all the way to the far eastern part, which is back and forth under Russian Ukraine and bombing. Terrible story. But be it as it may, and I can talk all about this, but the one thing is that I noticed as we're trying to get to the institution these different days with the BBC, across the landscape, you have to go through military checkpoints. So you're going through these checkpoints along the roads, and they have these barricades, these like concrete barricades, and you have to kind of wind yourself through these, and they're basically made of tank buster barricades, like these big metal things. I'm sure there's a different word for them. And then there's the military police. So, and, I'm sitting in the back. Eric Rosenthal is the passenger side. There's Helena. And we also picked up another woman who's part of their interpreter team. There's 4 of us. And there's the BBC in another Jeep. And so Helena rolls down the window, and she, the military comes up, and they're like looking around, and they're like, well, who are these Americans? So, and you can see her speaking back and forth in Ukrainian, and it was very surreal. And at one point, they took our phones away.
Did you ever wonder if you might not get out?
Well, I never thought that way. The only time I thought that way is when the BBC, our colleagues that we met, told the story of some of their colleagues near another part of Ukraine, where their Jeep of BBC people actually hit a bump in the road because the roads are not paved in certain areas, and it flipped over and they were injured. Yeah. So one thing that I felt probably is more precarious wasn't the Russians, it wasn't the barricades. It wasn't, I mean, they were doing their job, and I respected them wholeheartedly. I never really felt fear they're going to pull me out. Honestly, never. Even when they took our phones from us at this one, I won't get into that story. It's a little more personal. But even when they took the phones from us and looked at our phone and made us like open it up a little bit, I really thought it was a surreal experience, and I could sure. But I think once we got to the institution, that's when the shock culture came on.
That's what I was going to ask you. So what did you see in the institutions?
Well, it was very sad because basically what I did, we went to 4 different institutions in this different area. One of them was what was called a baby house, and the baby house is basically an orphanage. And what it is in the culture in Ukraine, this is the culture of Ukraine. This is kind of where, me wearing an American flag and going to Ukraine and understanding American values is in these countries, in post-Soviet Union bloc countries like Ukraine, Romania, and others, Russia, is that their culture is institutionalized care. They devalue people with developmental disabilities of not having great value from day one. They don't have family supports. They don't value them as human beings for the most part. And the state, the government, basically creates this framework of institutionalized care as babies. So they have a discussion with families, when the child's born. The doctors obviously must be very involved in this discussion, like it was many years ago in the United States, where the doctor would go to mom and dad, you got someone with Down syndrome or something like that.
Best thing you can do is put them in an institution.
Absolutely, and that's what happens. So not only that, but they don't create, and they have not really created community support for the family. So it's bad enough that you're going to care for, the state's going to take them, but just say you want to be able to care for them like you would your son or daughter anyway. They don't build into their society community-based supports like the United States has with different organizations that we all have throughout our country, even though it's not perfect in that way either. We all are striving for resources. But what happens is that the state takes them over, and there is no early intervention. And early intervention, Let's talk about someone who can't swallow well. Let's talk about someone that has spina bifida and they need a surgical intervention to correct spina bifida.
They're not going to get those, most likely.
Let's talk about hydrocephalus and needing a shunt. Let's talk about spasticity care. Let's talk about language development. Let's talk about social development, early intervention. So if you're not getting early intervention from day 1, day 10, day 50, day 100, do the math. So if you're not getting early intervention, it becomes survival of the fittest. So you have early death, early on in infancy. They're not surviving, they're not living, and the people that are living in, this is the different institutions. So I went from one institution, and it's basically age groups. And you basically almost see this progression of loss of abilities. So as I start seeing the older group, and the older group we're talking about their 20s, they're basically people who never got spasticity care, and they're basically their tone, their extremities, their arms and legs, and even their oral health care. It's sickening. I mean, it's really tragic. And the other part about it, and since there is war going on, what there's been refugees certainly flooding out of Ukraine into other countries, but what they've also done in Ukraine of their institutions, the institutions that are all toward the east where the war has been mostly brewing, they've actually moved another people from the eastern part of the institution to the western institution. So you see a flooding of some people from other developmental centers into the ones that are on the west where we saw, and you saw them, they would say, oh, this person was at this institution there and there, and they don't carry records with them. They don't have enough staff with them. So going back to early onset Alzheimer's and Down syndrome, and the fact that I treat geriatric, and this is kind of a setup question, how many people do you think I saw that had early onset Alzheimer's with Down syndrome?
And that would be 0.
Exactly.
Because they never got that far.
That's exactly tragically true.
How does that relate to
That's a fact.
the United States?
Well, basically, in the United States, the lifespan of people with Down syndrome is now, in the 60s and 70s. But because of the fact that people with Down syndrome, 60% by age 60, 90% by age 65 are getting Alzheimer's disease, you see all of a sudden as their life expectancy going up over decades and decades and decades, they get Alzheimer's disease. So the number one reason why people with Down syndrome die is Alzheimer's. So Alzheimer's takes the life away of people with Down syndrome almost all the time. So it's this tragedy waiting to happen. So I think philosophically, I look at this situation. I don't have a child with Down syndrome. I care for a lot of people with Down syndrome is how philosophically one thinks about early onset Alzheimer's disease in someone that has Down syndrome that's younger. How does one grapple? And I don't have the answer to this question. It's almost like this rhetorical kind of comment, I suppose. How does one deal with as a mother, father, an agency, 10-year-old Down syndrome, 20-year-old Down syndrome, and knowing that in 10, 15, 20 years, all of a sudden they're going to hit the wall and develop this horrible regression and die? And how does one even begin from an organizational standpoint, family standpoint, societal standpoint? At the same time of that, what's going on now all around us, there's now these developments of treatments and these developments of what are called biomarkers. And Craig, it's a fascinating story. And I just was in the American Academy of Neurology. I'm a leader in the American Academy of Neurology for developmental disabilities. I'm a leader in that way. And last week, it's been a week, I've been traveling all the time. Last Tuesday, I had a special meeting that I brought together I brought together a meeting, and it was all related to this issue.
So I tell you what, Seth, let me bring you back.
Okay.
And then we're going to talk about developments
Yes.
in neurology
Yes.
and dementia.
Okay.
How does that sound?
Yes.
Does that work?
Yeah, sure.
All right. This has been unbelievably fascinating.
Okay.
From dementia, from AADMD standpoint, from what you've done in Ukraine, which it's incredible. I can't imagine having that experience. So all I can say is thank you so much for sharing this with me. But you are going to be back.
Okay.
And we're going to talk more about dementia.
That'd be great.
All right.
I appreciate the opportunity.
Thank you so much, Seth.
My pleasure.
For being here, and we'll do this again soon.
Thank you very much.
All right.